Now, on the topic of orientation, so I have worked at this hospital before. I know some of the people that work there. I know the manager. Orientation was fairly quick. So my first orientation day was a Monday. I spent 8 hours there. It was like a 7 to 4 kind of thing. Literally just listening to the educator talk about policies, procedures, setting up my badge, setting up my email, my payment account, all the other picks and stuff that I gotta do. Just signing a bunch of papers, just trying to get that figured out. We also did a little bit of a tour of the hospital. Got to meet some people that I used to work with because I used to work there on nights. A lot of the people that used to work there on nights are now days. So it was nice to just say hi, get to talk to them for a little bit while exploring the unit that I knew fairly well. So that was nice. It was nice catching up with manager because when I started there, the manager there is currently in position. She used to be the clinical educator and she moved up. So it was nice having her there and just talking about her experience and just catching up. And the manager that used to be manager there, she got a higher position, and actually on the same day of my orientation, she actually came back. So I got to meet my ex-manager while catching up with my current manager. So that was actually really cool, really cool experience. Just taking a look at, in a sense, how I first met these people and how they moved over the last 3 years to different positions and different roles in a hospital. It gives you like an interesting perspective on the flow of people's nursing careers, because the current manager, she used to be a nurse, then she became an educator, and now she's a manager. And the prior manager, she used to be a nurse, became a manager, went to a different hospital, became like the DON there, and now she's coming back for a different position at this hospital. So it's like really cool to reflect on all the stuff that I did so far in my career and all the stuff that they've done in their career. But keep in mind, they're like 10 years older than me, 10, 15 years older than me. So they have a lot more experience, they meet a lot more of the criteria for moving up in a nursing hierarchy, you could say, or nursing chain. Looking around, looking at people, I see some people that became NPs, went back to school, did this, now they're managers or they're caseworkers or do all that kind of stuff. And you feel like maybe you missed out a little bit, but that's a feeling that everybody gets. There's for sure some nurse practitioners or case managers that look at me and feel like they missed out on travel nursing. They didn't get an opportunity to do it, and they would love to do it. Now they feel kind of stuck. That's what everything. That's how human beings are. We always look at what people are doing as better than the way we did it, but that's completely incorrect. It's just our need to want something that someone else has. That's everything. It's with cars, it's with jewelry, it's with money, it's with work, all that kind of stuff. It's with the physique, all that. But to get back in here, it was really nice to catch up with everybody and just seeing how everybody progressed, everybody changed, how they matured. It was very nice. So that's basically what I did for my first orientation day. My second orientation day was me completing more modules. I did some Epic coursework because we're using Epic in the system. I had to do a bunch of modules. I think the modules took me like 10 hours to do. I'm going to say 10 because I got paid for, I think, like 10 hours of them. So I'm going to say they took me 10 hours to do. But the Tuesday was a big module day. I did a lot of Epic stuff. I stayed there for like 4 hours. So that was nice. I got some coffee. I just walked around the hospital, explored a little bit. Met with my educator again just to touch base on where I am. She also said I could try to test out of the EKG module. So basically gave me the exam, and if I could test out of it, I don't have to do the really long course. So on Tuesday, I did a just a little simple orientation. That was a big module day, and then I found out some more information. So then Wednesday, another orientation day, but this day was just focused straight up on just modules. I had to do a Epic Test Out exam, and I did my EKG Test Out exam because I just decided to study for it. I just looked at some Epic videos just so I have to take the giant course, because if you don't pass the Test Out exam, the charting course is going to be easy, like at least anywhere from 1 to 3 hour course. And with the EKG, if you don't pass that, you don't test out of that, you're doing a whole EKG course again. That's going to take you like at least 3 hours. So I diligently studied for those Tuesdays so I could take them on Wednesday. And I was able to pass the Epic. That one I was a little bit worried about because the first one was charting like the pain and like the pain score and the pain location. But this is a higher tier of Epic because different tiers of Epic. And I got the first like 3 wrong of the pain section because you know how you normally type in the pain location? This one, you had to go on the LDAs and actually press on the location on the little avatar of where the pain is. And I didn't know we were supposed to do that. So I was trying to figure out like where the heck do I type in this pain? There's no box for pain, but you actually do it in the LDAs. I later on realized that when I was just reviewing what I got wrong and that kind of stuff. All the other ones I passed completely. It was just that beginning steps that I didn't know what to do because I didn't realize that they require you to use the LDA avatar for the pain location. So after that, I was like, okay, well, this is the first one. I maybe got 2 out of the 6 right. I'm definitely not going to be able to pass, but it got easier as time went on, and I was able to figure out more of what to do, where can I find this, where can I find that, just because of my Epic experience. But the EKG exam, guys, man, I was so worried about that one. I was so worried. I know my EKGs, I've basically been doing EKG strips every shift of my nursing career, but it's one of those things where you're just like, I don't want to get it wrong because it's like 50 questions, and if this is 50 questions, and if I miss a handful, you got passed with 80%, so if I miss like 10, then that puts me at a disadvantage. I got to retake the course because you don't see every single EKG rhythm there, so sometimes it gets confusing, especially if you go into the heart blocks, the Winky box, the type 1, type 2, all that kind of stuff. That's a little bit confusing. That's the ones that they tend to throw at you the most. But this EKG exam I'm going to tell you guys, it was probably the easiest EKG exam I have seen, probably because I have a lot of experience in it, so I probably just over-worried. I probably thought it was going to be worse than it was, but there was a handful of questions where one of the answers was to assess for a pulse, assess the patient, and call the physician with the rhythm change. That was one of the choices that you could pick. So I'm looking at that. I'm like, okay, well, this is nice. If it's not sinus rhythm, and if it's presenting with any kind of symptoms, you're going to always assess and call a physician. So that was a little bit of a cop-out in a sense because it's an easy answer to select. So I never seen this before. Usually it asks for what medication would you use or what would you do. I've never seen EKG exam give you one of the answers as assess and call a physician and wait for order. So that was nice because those are almost like free answers. And even in the ones where that answer is not correct, if it's sinus rhythm, you don't need to do all that extra stuff, right? So that was easy. That was very nice. So then Wednesday I did all that. I finished all my modules in that one day, and then Thursday came. Thursday was my actual in-hospital orientation, and that was nice. As soon as I came in, one of the assistant managers that knew me, I worked with her in the past, is like, all right, Peter, well, you've been here before. We're going to give you the full work. So, and during my orientation, I was obviously partnered with a nurse, and we had a patient that was fresh from a mitral valve clipping. A mitral valve clipping is something that they put on patients that have mitral valve rigor to better open and seal that mitral valve so they have better cardiac output and the blood doesn't backflow through that mitral valve. So yeah, that happened to him. But after the procedure, a little bit during the procedure, he had a little bit of a cardiogenic shock going on. So they had to give him a balloon pump and they gave him a Swan. And not to mention, he is also a dialysis patient of 7 years. So they gave him a dialysis and he was on CRRT. And we were going to be the ones to start the CRRT. We're the ones that got him out of the OR. This was a night shift. So the patient got back a little bit before 6. So the day shift nurse, only thing she really did was slave the balloon pump to the monitor, set up the Swan lines, and then also start the CRT chamber. So she was priming the cartridge, which was which was nice because we didn't have to do it. The hardest part about CRT is usually getting the cartridge to work for you, because any kind of obstruction of flow, any kind of air bubbles that's going to alarm, you have to be really diligent and do it right so there's no air in the system, because I'm telling you, the system goes wild if there's any kind of air bubble. But I kind of wished I was able to start the CRT myself and the cartridge, because it would give me a nice refresher on how to start the actual CRT, how to prime it, all that kind of stuff. But even though it is step-by-step directions, I'm more of a hands-on person. For me to learn how to do something properly in the correct way, I have to be able to touch it, I have to be able to move it, I have to be able to mess with it, I have to be able to actually do it. That's the way I remember best. I'm not the kind of person that reads something and, okay, I got it, and we'll see what happens. I have to get a good feel for it to be comfortable with it. So I didn't get to prime the CRT machine, but we did get to start the CRR machine. So we got our little paper with the ultrafiltration, all the pressures, the venous pressure, the atrial pressure, all that kind of stuff. So it was nice jumping into orientation and having this critically ill patient with a balloon pump, with a Swan, with a CRT machine. So this guy Dallas is of 7 years, so he knew the whole protocol. He never been on CRT. He was completely with it. He was 8 times 4, able to move all extremities to the best of his ability, because of course the balloon pump was in his femoral artery. So we have a brace on the leg so they don't bend it, they don't mess it up. And it also had a Swan in his IJ, so that restricted his neck mobility, and then paralysis also in his lemfem by that balloon pump. So a lot of stuff going on. We were just turning him every couple hours, all that kind of stuff. So this was, I want to say, a perfect learning experience and almost a perfect first orientation day, minus the fact that I didn't prime the CRT. And why I say that is because this guy was completely with it. He was a super nice guy. He followed all our instructions. He asked good questions. He slept fairly well. And I was able to do my numbers on the Swan. I was able to get my numbers from the balloon pump and also do the CRT at the same time without him trying to die, in a sense, for lack of a better phrase. He wasn't trying to die on us. He was with it. He was, you could say, in a healthier state. His numbers weren't bad. So it was a nice patient to get to learn the ropes. And it was a perfect patient to get back into the routine of things, get back into the feel for things, especially working with a balloon pump, a Swan, and a CRT, which a lot of our patients have on this unit that I currently work at. And what's also nice is all the numbers were good, so we didn't have to troubleshoot anything. He was bradycardic, and he was having some PVCs, but he said he's normally bradycardic. He was like high 30s, mid 40s when he came back, but that was kind of normal because, of course, the sedation medication is still there. And back once the shift moved on, a couple hours in, he started being more like high 40s, low 50s. So that was a good change. Nobody was really worried about it. I wasn't really worried about it because that's his normal. He was just a little bit more bradycardic, you could say, because of the whole sedation that he got, all the medication that he got. So that was good. The CRT, the goal was to pull 150 mLs of fluid, and guys, we got to that goal without any kind of pressure issues, because you might notice that when you have a CRT and you start pulling fluids, you might see your blood pressure drop. This gentleman's blood pressure maintained very well the whole shift. It didn't even change. It was always anywhere between low 100s to 120, sometimes mid 90s when he's moving around. So anywhere from mid 90s to 120s, that's how much it stayed the whole shift. So we gradually started pulling. We started to go up by 25. So we started at 25, then did 50. Maybe remember this, if this is 25 or is it 50. I'm pretty sure, yeah, we started 25, then 50, then 75, 100, 125, 150. Yeah. So we slowly went up by 25. So the first hour of the CRT, we didn't pull any kind of fluids. By that, I mean, we didn't take out any fluids. So whatever he got in, we took out. So he was on, the KVOs for all those lines. He was on dobutamine, 5 milligrams. So I had to add up all those pump numbers. So he was getting, I think, like 45 mLs an hour. And he was getting 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 for the KVOs and all the other fluids. So we had to pull that out the first hour. So you're pulling that out the 45, and then plus when I did the Swan numbers, that's another 30. So we were pulling out, I want to say 75 for the second hour. The first hour, we let it run. The second hour, we pulled whatever you gave the last hour, and that was the 30 mLs of injectate and then 45 mLs of the medication and fluid that he got. So we weren't at a not negative yet. We were doing just a zero. Whatever we put in, we're taking out. The third hour, that's when we decided to take out 25 mL. So on top of that 45, we also took out another 25. So that gives you 70 mLs of fluid that getting taken out. I didn't add the injectate that time because I didn't shoot numbers every hour. We only shoot numbers two to three times a shift, usually 3. When you get there at midnight, and then about 4 o'clock in the morning before you do your mixed units or after you do your mixed units, whichever one time allows. So I only have to account for that injectate just during the time that I push it. So the second hour, so the first hour, like I said, we just let it run. Second hour, we took out the 70, the fluids, medication, and injectate. Third hour, we took out the medication and 25. So he was then finally operating at a negative 25 in a sense. And then every hour, as long as his pressure is held, we went up by 25. Some nurses would go up by 50. It's your judgment call. If you think their blood pressure can handle it, go for it. His CVPs on the Swan were anywhere from 9 to 13. So that does show that he has some fluids on him. Probably good to take that fluid out. And then we eventually got to that 150, I want to say maybe 6-7 hours into the shift. And ever since we got to the 150, that's where we stayed at. And we were able to get that negative 150 for the last, I want to say 4 or 5 hours of the shift, which is nice. Swan numbers were all good. Index was good. Output was good. CVPs towards the end of the shift did start to go down by 1, but you're not pulling too much fluids, but you're pulling just enough. So textbook wise, this was a perfect scenario. CVPs going down, cardiac index staying well, cardiac output within parameters, SVR is within parameters, balloon pump was 1-1, is working fine. We're getting a cardiac output, CRT machine pulling out the 150. Textbook, everything was going according to plan, and that's the way it stayed. His labs in the morning were also good. We didn't have to replace any kind of electrolytes. Hemoglobin was steady. Platelets were fine. INR was fine as well. It was downtrending. So normally if you have somebody on a balloon pump, a Swan, all this kind of stuff, usually with the balloon pump, Swan not so much, CRT not so much, but if you have a balloon pump, you want to have this person most likely on a heparin drip. When he came on his shift, there was orders for heparin drip, but he was getting some hemoptysis. He had a lot of bleeding coming out of his IG where the Swan was. So we got the chargers. We spoke to the nurse practitioner, and we decided to not start the heparin. We redrew the heparin. It was like the PTT was like 160s, and then we redrew it again a couple hours later. It was still like in the 120s, and then in the morning it was, I believe, in the 60s if I remember correctly. So we didn't start the heparin because he was just bleeding from his line size. He was bleeding out of his mouth. So we felt that let's not stir the pot. His PTT is high anyways. Let's just wait a couple hours. Does look like he's going to have a clot if we decide to hold his heparin overnight, and that's what he did. And in the morning we passed it down. Dad talks about starting again. They're going to talk to our team. Most likely after I left, he probably got put on the heparin drip just for safety, all that balloon stuff and all that kind of stuff. So everything well, guys. Balloon pump was 1-1. Swan numbers were good. Mixed venous, if I remember correctly, I believe it was 71. It was either 60 or 71. I forget which one it was, and that's good. That's good for the patient. No complaints. We'll take that any day of the week. So that was nice. So that's how I kind of manage my night. I like CRTs because every hour you're in there doing something, so time goes by real fast. But what does suck is if your patient's crashing and you're doing CRT, because when your patient's not doing good and he's on top of that you have CRT, you feel like you're so short on time every hour because you do your numbers, and try to do everything that you can to keep this person alive. And by the time you know it, it's already the next hour, already your next numbers, and it's almost like you don't have a chance to sit down when you have a critically ill CRT, because you're in that room so much and you're required to be there every hour to get those numbers and change up how much you're pulling and all that kind of stuff, where time just passes by so slow. It's with CRTs, it's either you're busy the whole shift, like a calm busy, or you're just sucking air for time. You're just so busy where it's like you almost don't have time for anything. But it was good. So when I was looking back at it, I was trying to figure out what's gonna be the plan for this patient. So some brainstorming things that came to mind was CRT is 1-to-1, not CRT, I'm sorry. Balloon pump is 1-to-1. He's augmentating well. His pressures are doing well. Looks good. They're probably going to try him on a trial of 1-to-2, see how he does. So with the 1-to-1 balloon pump, every time your heart beats, the balloon pump does the same thing. So when your aortic valve opens, the balloon pump closes. When your aortic valve closes, the balloon pump inflates. It deflates when the aortic valve is opened and inflates when the aortic valve is closed. Why it does that? Because imagine if the aortic valve opening and pumping blood and the balloon pump is now inflated. Where's that blood gonna go? It's not gonna know where to go. You're gonna pop someone's aorta. You're gonna kill the guy. So you have to have it. You have to have it beating in that synchronous way. So what happens usually is, if a patient's doing good on 1-to-1, augmentation is good, pressures are good, they usually trial him on a 1-to-2. So it's not every single beat. Now it's every other beat. And the purpose of the intra-aortic balloon pump is just to increase cardiac output. You could say decrease the work of the heart in a sense, because it's helping with the pressures and the output and outflow of blood. So you trial him on 1-to-2, see how he does. If he does good on 1-to-2, probably leave him 1-to-2 overnight, see how he does, all that kind of stuff. And maybe on the third night or third day, fourth day, you could pull out that balloon if you think he's doing well on 1-to-2. But before you pull it, probably turn it off, see how he does, just in case something happens, you got to restart it, all that kind of stuff. There's also a 1-to-3 setting, but I haven't seen 1-to-3 being used very often. It's usually, if they're good on 1-to-2, then they're stable enough to get it taken out. With the CRT, he did very well overnight. I want to say they want to keep him on CRT for maybe one more day, just to kind of make sure, check all the bases, and then probably put him on hemodialysis. This gentleman did have official, like I said, he had 7 years of dialysis, end-stage renal disease, renal failure in this sense, and he was used to it, and he was doing very well in CRT or pulling fluid. So I don't see why they would not maybe try to do some HD either the following night or just the next day, just because he's doing very well. The Swan, that's what they usually pull last, so he'll probably have that in before, all the way until either the day before he has to leave or before he gets transferred over to a unit. Because if the balloon pump is out, if he's on HD now, the Swan still gives you a lot of good information. You still see how well the lungs are working, in a sense, how you could see how well the lungs and a heart are working together. Because remember, with the Swan, it's going into the pulmonary artery. So this is the last point of pressure measurement is going to be your pulmonary artery. You get a wedge pressure, you get your CVP, you get your like I said, pulmonary artery pressure, all that kind of stuff is very valuable when you're looking at heart failure, when you're looking at fluid management, when you're looking at how well this patient's heart is functioning. So you want to always pull that last. We have Swans. I want to say almost every single patient in our ICU has a Swan. It's a really good measurement. You can get your mixed venous off of there. It's the last thing we always pull, because it gives us some kind of a data, and very, very valuable data. So that's how my shift went. I'm going to try to be doing at least 1 to 2 shifts a week. This is my first, when this podcast episode comes out, I'm going to be doing my first shift alone as a registry nurse. So maybe I'll touch back on it on my next episodes. But once a nurse, I guess always a nurse. it comes pretty natural to me now. I've been a nurse since 2016, 2017, so I've seen a lot of things. But I also learned a lot of things. So we'll see how this goes. I'm currently working once a week with the goal of maybe doing twice a week, and of course picking up those crucial shifts